Good afternoon. My name is Mike Masding. I'm a consultant physician and I'm co-chair of the UKFPO. And I'd like to welcome you, those of you who are watching live to this webinar. And I'd also like to welcome those who are watching it on catch up on the recording as well. The topic of today's webinar is e-portfolios, how you can learn as a foundation doctor through your e-portfolio, through reflection, and through good quality written feedback. I'd like to welcome my fellow panel members who you'll meet in a minute. Dr. Lauren Lockery, who's an F2 doctor from Northern Ireland, and Dr. Lorraine Parks, who's a consultant anaesthetist and foundation school director in Northern Ireland. And together we're going to take you through these topics. As I mentioned, the webinar is being recorded and will be available for a catch up via the UKFPO website and through the UKFPO web YouTube channel. If you've got any questions throughout the session, then please feel free to put them in the Q&A tab on the Teams link here, and we'll do our best to answer them. So to start off with, I'm just going to talk a little bit about some general principles of using an e-portfolio. Lauren is going to give some top tips from a current foundation doctor, as she is. I'm going to talk a little bit about reflective writing and getting the most out of that. And then Lorraine is going to give some thoughts about how we can improve the quality of written feedback that foundation doctors get. So starting with the e-portfolio, what is a portfolio? Well, if you look in the dictionary, there's a whole lot of different things that it can be. One description, a large thin case that you may have seen people use for carrying drawings or documents. In itself, that collection of drawings and documents that represent the work that a person has done. So that perhaps could be an artist, a photographer, something like that. A portfolio could be a collection of shares and investments that one has. I'm talking about other people here. Unfortunately, I don't have any, but any shares or investments that someone has. And indeed, we often talk about a portfolio that a member of the government has. So we might talk about a minister having a particular portfolio. And indeed, there's often a minister without portfolio. So how have we got to the point where foundation doctors have an e-portfolio? Well, probably the best way of illustrating it is thinking about it in terms of those first two definitions. It's obviously not a large, thin case, although when the foundation programme started 20 years ago, it was a very thick paper file that all foundation doctors had to complete. But it has now been converted into an electronic depository for documentation of the performance of a foundation doctor. And what I'd also like you to think about is it's a collection of those documents that represent you as a foundation doctor and your work. And so the portfolio is not a collection of documents for your supervisor to look at, but rather it's a collection of documents, a collection of forms for you to show what you have done. And to, in many ways, show how excellent you've been. So it is that collection of documents, that collection of forms that allows you to show what you have been doing. And what is the function of your e-portfolio? Well, in many ways, thinking about it from the point of view of a foundation school director like Lorraine and I, it really has two different functions. There's the regulatory function. All doctors, once you've qualified, so as soon as you become an F1, are under the regulation of the General Medical Council. And all doctors, so right from now, when you may have just started in your career, right up to the point where you relinquish your license to practice when you've retired, you will be regulated by the General Medical Council. And so our e-portfolio has a function of this. And it's worth saying at this point that you will have something like your e-portfolio probably for the rest of your career. I have one. I actually have my appraisal later this week. All consultants have an annual appraisal, and I have an e-portfolio where I collect evidence of what I've been doing over the last year. So there's something about the e-portfolio showing that you're progressing satisfactorily. We use it at ARCP, the annual review of competency progression. That's something you will have towards the end of the year. And we will be doing webinars about the ARCP later on in this academic year. But through collecting the evidence in your e-portfolio, you can show that you've achieved all of the curricular outcomes that you will need to do. And in doing so, you will show that you can safely progress to the next stage of training. So if you're a current F1, you can progress to F2. If you're a current F2, you can progress onto the next stage of training, whether that's going into a locally employed doctor post or a training post. So there is that regulatory function of your e-portfolio. But I also think that it has a formative, a developmental function for you as a foundation doctor. Whilst we do want you to progress satisfactorily, I'd rather you progressed well. But we often talk about competence, but if I was taking my bicycle to a bike shop, I actually don't want the mechanic to be merely competent. I want them to be excellent. I want them to diagnose what's wrong with my bike. I want them to fix it well and as efficiently as possible so I can then ride it off into the sunset. So it's not just about meeting the bare minimum. It's actually about showing that you're doing really well. It's showing that you're thinking widely about your role as a doctor. Being a doctor is a really complex thing. It's not a transactional role where you're asked to do something and you just do it. As you progress through your career, you'll make increasingly complex decisions. And indeed, you'll already be making complex decisions, although you may not be thinking like that, or you may not be thinking that they're that complex, but they actually are. And so what we want in your e-portfolio, and I'll talk a little bit about reflection later, is that you're actually thinking about your role as a doctor, what you've been doing and how you've been impacting on patient care. And of course, it's an opportunity for you to show off your achievements. You achieve an awful lot. We've got the National Foundation Doctor Presentation Day in January. And I'm always amazed at the fantastic things that foundation doctors present there, the amazing stuff they've done during their foundation program. And having that in your e-portfolio, as well as showing that you've reached the competent level, it also shows your achievements and that you've done much more than that. So those are the principles of an e-portfolio. Think of it as having a regulatory function, but also a formative or developmental function. I'm now going to stop sharing and hand over to Lauren, who's going to give you some top tips about how to get the most out of your e-portfolio.
Good afternoon, everyone. My name is Lauren Lockery, and I am one of the current foundation doctors based in the Belfast Trust in Northern Ireland. I'm delighted to come along today to give a brief overview of the portfolio, touching on both Churas and Horus. My best piece of advice would be to get familiar with the portfolio early and enjoy it. I found building my F1 portfolio a very enjoyable and satisfying process, and it felt like an achievement to look back on at the end of the year. Today, I hope to give a brief overview of the portfolio and my top tips. I am aware there are doctors here today who use both Horus and Churas. The exact format of each system is different, but each contain nationally agreed core content, such as PDPs, SLEs, and reflection forms. I personally use Churas, so a lot of the screenshots you will see today will be from a Churas portfolio account. As foundation doctors, we are all expected to be responsible for our education and development and to reflect regularly on our performance and feedback, and we can do this via our portfolio. Firstly, the F1 curriculum covers the 3 HLOs and 13 foundation professional capabilities. I won't go through them in detail today, but further information can be found on the UKFPO website. Each SLE and reflection that you do should be linked back to the curriculum, and you must show evidence of linking to demonstrate progression. Some things you will find are easier to link than others. For example, HLO1 can be easily linked to SLEs, and HLO2 and 3 can be easily achieved via e-learning or reflection. During the first rotation, you're expected to complete your TAB, which is Team Assessment of Behaviour. It is recommended to complete the TAB in October, hence October. It involves sending out feedback forms to a range of people from the MDT, such as consultants, doctors, nurses, allied health professionals and pharmacists, and getting back 10 of these forms. I would advise sending these out early and to more than 10 people so that your TAB will be complete for the end of rotation 1. It's a lovely document which you will receive just before Christmas time with lots of positive feedback. It is really nice to read the positive things that members of your team have said about you, and it's a lovely little Christmas present. During rotation 2, your clinical supervisor will send out similar forms for the PSG to a range of people you work closely with, and they will provide feedback on your clinical performance as a foundation doctor. The next thing we will discuss is core and non-core learning. You're expected to keep a log of core and non-core teaching, and you require a minimum of 30 hours each during F1. Core learning will be provided by the Trust, and this involves turning up each week and logging it on the portfolio. It can also include simulation training. Core learning topics include mental health, end-of-life care, and health promotion. Non-core learning can be obtained via script modules, e-learning for healthcare, BMJ modules, and departmental teaching. The next thing we will discuss is personal development plans. A PDP allows you to identify learning objectives for each clinical rotation. You should create a PDP based on things that you want to get out of each placement and review at the beginning with your supervisor. You should identify specific objectives and outline how these will be met. You will review your PDP at the end of each rotation and reflect on how you achieved each of the objectives. As F1s, we must show participation in quality improvement projects. Evidence of at least one quality improvement project is a mandatory requirement for the end of year ARCP. QIPs are very easy to get involved in. If you ask around, there are usually multiple QIPs going on within your department. Pharmacy often do large QIPs which you can help out with, or if you like, you can do your own. During F1, I got involved with a departmental QIP on NG tubes and a pharmacy QIP project on paracetamol prescribing. Reflection should be used to highlight and learn from both positive and negative experiences in order to demonstrate professional development. You can choose to reflect on things that have went well, things that did not go so well, and on difficult patient encounters. You can also reflect on different FPCs, for example, personal well-being and raising concerns. Some examples of things I reflected on in F1 were receiving positive feedback from staff and patients, reflecting on my first cardiac arrest as an F1 and on raising concerns. Supervised learning events include mini-KECs, case-based discussions, DOPS, developing the clinical teacher, and learn and leader forums. SLEs are a way to provide evidence of coverage of all aspects of the curriculum, and in providing feedback can highlight areas of excellence and suggest areas for further development. The minimum requirement per each 4-month rotation is 5 SLEs, however, you're free to do more if you wish. Each SLE can be linked back to the FY1 curriculum and can show progression throughout the 13 foundation professional capabilities. Firstly, we will discuss mini-KECs. Mini-KECs involves a supervised patient encounter. If you review a patient, for example, on a ward round or out of hours, most seniors will often offer to complete a mini-KECs for you. I found the best place to get mini-KECs is out of hours when reviewing an unwell patient and during ward rounds. For example, I have included a mini-KECs on reviewing an acutely unwell patient during a night shift. You will give a brief description of the case, write about your assessment of the patient, your findings, any investigations you ordered, and any treatment provided. You will choose a clinical problem category, and then most importantly, you will reflect on the clinical encounter and link the case back to the FY1 curriculum. Case-based discussions essentially involve discussion of a patient's case. This can be through seeing an interesting patient during a ward round and discussing their condition or management plan with a senior, or when referring a patient to another speciality for advice. You can also count this as a CBD. I completed a CBD on vena cava obstruction. After assessing this patient, I contacted my senior who came along and assessed the patient, and we had a lengthy discussion on recognising SVCO and the urgent management of this, which then involved contacting acute oncology for advice. Usually, you will have more of a reflection in CBDs and include a bit about what you've learned from the discussion and how it will form your future practice. DOPS involve carrying out a clinical procedure under direct supervision of a senior and receiving feedback on your performance. For example, during my respiratory rotation, one of the points of my PDP was to learn more about chest drains, so my DOP for this rotation was removal of a chest drain under direct supervision of the consultant. Examples of DOPS could be inserting NG tubes, administering hyperkalemia kit, removing drains, or taking blood from a PICC line, all under direct supervision of a senior. DOPS are a good way to demonstrate evidence of achieving points on your PDP. During F1, it is recommended to get involved with teaching. Lots of opportunities arise to get involved. For example, teaching medical students, teaching within your department, or teaching fellow FY1s. You can create a Developing the Clinical Teacher form where you will write a small description of the teaching that you've done and get feedback and reflect on this. Learn and Leader forms. You can create a Learn form to show how you've demonstrated any one of the 13 FPCs. This can be done via CBD, Minicex, DOP or DCT. For example, you could submit a Learn form to your clinical supervisor on FPC1 clinical assessment through doing a Minicex during a ward round. You can reflect on the encounter, on what went well, what challenges you encounter, and plan the next steps. For example, getting more practice or seeing more complex patients. Your supervisor can then give you feedback and advice on how you should progress with that particular skill or FPC. If you've demonstrated leadership or took a lead role, you can submit a leader ticket to a senior for feedback. For example, I took a lead role in education and received feedback on this. So lastly, my top tips for portfolio are: be proactive and start the portfolio early. Organisation is key. Aim to update your portfolio on a weekly basis and split it up into manageable chunks. Complete your tab in October and always send out more forms than you need. Raise any issues with the portfolio early on in the rotation. Speak to the F2s if you have any issues, as they have just done this before you. Try to attend core teaching where possible each week and make use of the UKFPO website, as it contains lots of helpful information. Today was a very brief overview of the portfolio, and if anyone has any more questions about the portfolio, please feel free to drop me an email and I'll be more than happy to help as best I can. F1 is a very enjoyable year, and if you do your portfolio as you go along, you will enjoy watching your portfolio develop and will have no issues come the end of year ARCP. Thank you for listening.
Thank you, Lauren. What a splendid run through all that is in the portfolio, and hopefully you've got something out of that, and some tips in terms of getting the most out of your portfolio and ensuring that you get everything done. If you've got any questions, as I mentioned earlier, please put them in the Q&A tab and we'll answer them as we go along. So I want to talk now just for a few minutes about reflection. And it's something that I think it's probably fair to say raises a few concerns and hackles sometimes from doctors, both young and old. And what I hear all the time is that I reflect all the time. I reflect when I'm walking around. I reflect when I'm walking home or driving home or riding home. I reflect when I'm sitting having a coffee or other beverage with my colleagues. But there is something about reflective writing that has a particular strength when it comes to being a doctor. Firstly, what do we mean by reflection? Well, Here you can see that a doctor talking to a patient, and that's what we do. As doctors, we do it in lots of different settings and lots of different ways. But we talk to patients and we're looking at them when we're doing it, or hopefully we are. Reflection is actually the word is, about looking in a mirror and actually seeing yourself and seeing what you do. And what I will keep saying in the next few minutes is reflection is all about you. It's not about the patient. It's about you. It's about how you feel, what you can do to develop, and what you can do to be a better doctor. What do I mean by that? Well, the most commonly used model of reflection is Gibbs' reflective cycle, but there are lots and lots of others which are not hugely dissimilar to this. And this goes through various different stages where you describe what happened, how you felt about it, you evaluate your own feelings and analyze them, come to some sort of conclusion, and then make a plan for what you've learned and how you might act differently, if there is something to act differently in a future similar situation. I will probably have read literally thousands of reflections over my time, having been involved in the foundation program since its outset nearly 20 years ago. And I think it's probably fair to say that both doctors new to training, but also more senior trainees, registrars, even close to finishing their training, and indeed consultants, when I look at their appraisal folders, often don't really get past the description phase. And one could argue that as per Lauren's talk, if what you're doing is just describing what happens and having a discussion about what happened, that's a case-based discussion. And Lauren articulated that very nicely in her case about the vena cava obstruction, what happened, an in-depth discussion about why it might have happened, and then what needs to be done for the patient. Whereas again, I'm going to come back to reflection is about how you feel. So whilst the description is important to give the reader or indeed the reflector a context for what's happened, the description can be very, very brief, maybe only 1 or 2 lines. And indeed, some proponents of reflective writing would say you could just start by saying, I saw a patient. That describes what you did. And the important bit is not what happened with that patient, but how you felt, what you did, and what you have learnt and will continue to do in the future. So as we move through Gibbs's cycle, you're starting to reflect when you've moved on from the description. This arrow is very deliberately here, not here. So once you've finished with the description, that's the point at which you're starting to reflect about how you felt, about what went on. And remember, reflection doesn't always have to be about things that went wrong. You can reflect about things that went well. Why do you feel, good when someone says, thank you for looking after me, doctor? That could be the start of a reflection. You will then evaluate it in terms of why you feel like that. What are the different things going on that make you feel that way? And then as you move further round, you're then really starting to reflect and you're analysing your own feelings, coming to a conclusion about why you felt that way, and an action plan in terms of what you've learnt and what you're going to take forward for the rest of your career as a doctor, because we all keep learning. And then just to really emphasize, the description bit is the least important part of this piece of reflective writing. The most important parts, or it gets more important as you go further on round the cycle. And so many people just get stuck at this point of the description. Now, many viewers may be thinking, I don't like talking about my feelings. I don't like talking about, how what I'm thinking at any one time. But that is absolutely fundamental to being a doctor. We're not technicians. We are practitioners, we're professionals where our feelings, our thinking is an integral part of the care that we provide to patients. No one, I think, in my experience, gets this right. And I didn't get it right when I first started doing it, to be brutally honest. So the most important thing, like most things in medicine, or indeed most things in life, is try it out and keep practicing. And if you want to keep it really simple, then just answer these 4 questions. Describe what happened, but as briefly as possible. Don't want 3 or 4 paragraphs. It's really just as briefly as possible, to give a bit of context about why you feel that way. And then the next 3 questions about you. How did you feel and why did you feel that way? And most importantly, what will you do differently next time, if anything? What have you learned from this? Now, we have moved on in the foundation program curriculum from having a certain number of reflective writing pieces that each foundation doctor had to do. We do expect you to do some, but there is no set number. And indeed, you can keep it private, but actually there is a lot of evidence, and I believe that it's actually best shared. One of the other benefits of becoming a reflective practitioner and actually writing it down is that it can help you decompress. It can help you focus your feelings, make you feel make you realize why you felt a certain way, and then share it with colleagues so that they know how you're feeling. Again, many colleagues would say, well, I do this all the time when I'm thinking, but humans don't think in a linear way. We think in a scattergun way, and you'll be thinking of one thing, and then your bleep will go off and you think of something else, or your phone will go off, or you get a text, or you just think about something else. And that's how we think. Writing it down helps it to put it in a more linear fashion. It gives you a framework to think of the way through, so that you will get through all these stages, and most importantly, so that you will learn and develop. I would really, really recommend becoming a reflective practitioner. That's actually what we want and what our patients want out of doctors. You will often come across patients where guidelines and protocols are not going to be very helpful because they don't apply to that particular context, to that particular patient. And that is where, through being a reflective practitioner, you will help yourself to come to better decisions about what you're doing and learn more. So I'd really recommend you to try this out. There's no right or wrong in writing a reflection. You can write whatever you want. And I have genuinely seen people do it as a poem. I've seen people write pages and pages and pages, and I've also seen people answer each of these questions with just a few words, without any, not being a sentence, just a few words. So however you want to do it, develop your own style, but remember, it's about you and how you feel, what you have learned through something, and not necessarily about what's happening to the patient or what's happening to colleagues or anything else. So I'd really recommend you to try this out. Do it as much as you possibly can, and through that, I absolutely believe that you will become a better doctor. I'm now going to hand over to Lorraine, who's going to talk a bit about feedback and how that can help you to be a better foundation doctor. Lorraine.
Thank you, Mike. For the next 10 minutes, I am going to speak about good quality written feedback, and I hope this talk is equally useful to foundation doctors that are listening, and also to any foundation supervisors that are listening. All of us as doctors are lifelong learners, and as such, we receive and provide feedback on a regular basis. Often this is verbal and quite informal, but for the purpose of today, I'm going to focus on the more formalised written feedback that foundation doctors receive mainly in their e-portfolios. So, apologies. I'm just trying to get my slides to move. I'll come out for a moment if I can, because I don't think they're actually moving. Sorry about that. So why do we need feedback? Well, the main purpose of it is, I think, as has already been mentioned in this webinar, it's really essential for all grades of doctors, foundation and right up to consultant level, for continuing professional development. It also obviously enhances and facilitates reflection and continual learning and improvement, which is what we all aspire to as doctors. Very importantly, and particularly in a relatively time-limited training program, such as a foundation training program, it's really important to measure or have some sort of benchmarking of your own level of performance and progress. So everybody really wants to know how maybe their current level of performance relates to their previous level, such as if you're an F2 doctor, you might like to know, have you improved, or how have you improved since you were an F1 doctor? But also to inform your desired level of performance. So it's really important to know that you're continually improving and progressing as you proceed through your training. And as we've said, in terms of foundation, this is normally provided through your e-portfolio. So supervised learning events, which I'll mention in a moment, are the main way in which you ascertain or obtain more formative feedback and evidence of your improvement. And for your final achievements of your curricular outcomes, of the higher level outcomes and the SPCs, that is provided mainly through your TAB, your placement supervision group, and your end of placement reports from your clinical and educational supervisors. So that leads us on to talk about these types of written feedback. So the supervised learning events that Lauren described in your e-portfolio, the DOPS, the CBDs, the mini KEXs, they're quite formative means, as we say, and it's really important that these are seen as not something that are there to be passed or failed. They exist, as the name suggests, for you to learn from. And as such, you should not be perfect the first time you do a particular procedure, for example, and neither do you ever need to be perfect. It's all about continually improving. So it's really important that these are embraced, and supervised learning events are not thought of in a daunting way. They're there to provide you with the opportunity to learn and improve. Your multi-source feedback through your TAB and feedback through your placement supervision group, which then in turn helps to inform your clinical supervisor's end of placement report, which in turn assists the educational supervisor report. They are more types of summative feedback that occur towards the end of a particular 4-month placement, for example. But it's also really important that they contain the essential elements of good quality feedback to enable you to progress and develop further in your next placement, for example, or your next post. So these are all characteristics of good feedback. So really important, obviously, that feedback is provided in a timely manner when it's still fresh in the minds of both the giver and the receiver of the feedback. It's really important that feedback should be an accurate reflection of what has taken place or what has been observed. It should be honest and fair and non-judgmental. It has to be quite specific and descriptive of what is being fed back, and as such should be really structured in a way that is constructive. And the person giving the feedback, the supervisor in particular for foundation doctors, needs to be really aware of what is the expected level of performance of the young doctor. That in turn will obviously imply that they need and should be familiar with the curriculum and with the desired learning outcomes of the foundation programme. That will enable them to direct the feedback and suggestions for future development and improvement towards the agreed learning goals and align very much with the learning outcomes of the curriculum. And finally, good feedback should always include some sort of suggested action for further development and ongoing learning. So the next couple of slides, starting with this one, I've just taken anonymized screenshots of what I would perceive would be quite a basic clinical supervisor end of placement report for a foundation doctor. I'll just give you a moment or two to look at that. And as you can see, it's probably fine. It's sufficient. It shows that the foundation doctor is probably going to get signed off for that placement, but it doesn't really tell you very much else. And more importantly, it doesn't really tell the foundation doctor whose portfolio this is very much else either. It doesn't give them much in the way of building blocks as to what, if anything, they should or could be doing in their next 4-month placement, for example. So I don't think it feels particularly motivating or constructive. Maybe a better example of an end of placement clinical supervisor report would be something like this. Not saying it's the best, but it certainly feels like a better example. It has a little bit more specific language and examples, a bit more encouraging to the foundation doctor. And I think it shows that the clinical supervisor has really gotten to know the foundation doctor well and observed them quite closely in a variety of situations during their 4-month placement. Hopefully, it's more likely to motivate the foundation doctor as they would move into their next placement. So distilled from many of the end of placement reports, the commentary within tabs, PSGs, and feedback from supervised learning events in all doctors' e-portfolios that we tend to see over time, there's a lot of commentary that I think thematically are maybe less useful to the learner. And it would include comments such as somebody simply writing no concerns, which in itself, again, really doesn't tell anybody very much. It's quite frequently seen, but it's almost like the absence of a concern doesn't necessarily inform what the level of performance is. Comments like performing a procedure competently. It might mean you've had a lucky day and you've happened to do it well that day. Or equally, it could mean that you're really competent and in fact outstanding, but you don't really know which it is. And I'm guessing that most of you would like to know which it is. Should improve with experience, will improve with practice. What does that really mean? There's nothing specific there to actually show how the improvement will occur, or maybe in what areas of the process improvement is needed, and what you can actually do to get that improvement and progress. I think the final statement there is really just a factual statement rather than what I would regard as true feedback. It just is a description of something that was done and not much feedback. I'm going to finish on my final slide with what I think, and I hope you agree, is an example of much more useful feedback. I'm not going to read all of that. I'll just give you a moment to read it for yourselves. I think within this slide, it includes most of the elements that most foundation doctors would actually want when obtaining feedback, whether it is after a supervised learning event or just something more general within their multi-source feedback. I think for this particular example, we could assume this could be feedback from a supervisor when a foundation doctor has carried out a procedure such as inserting a line, maybe a lumbar puncture, maybe an arterial blood gas. They're just things that come to mind that this example might pertain to. So the first paragraph, I quite like it because it's a description of all of the aspects that the foundation doctor has done well, both the technical and the non-technical skills involved in this procedure. And I think the middle bit is really encouraging and actually suggests a way in which they could even be maybe more slicker and improve for the next time. And the final part, very importantly, is actually offering suggestions for additional supplementary learning opportunities that could both consolidate and build upon their current skills. So thank you very much for listening. I'll finish just with this quote. Feedback, when it's given well, should not alienate the receiver of the feedback, but should motivate them to perform better. And I think that's what we would actually all like to hope we're achieving when we're either giving or receiving feedback. So thank you very much, and I'll pass back over to Mike for any questions.
Thank you very much, Lorraine. And again, thanks to both yourself and Lauren for taking the time to participate in this webinar and for your excellent talks. So we've had a few questions. Many thanks to those of you who've taken the time to send those in. The first one I will direct to Lauren. The question is from Mohammed, who says, is QI, quality improvement, is it mandatory for foundation training? My understanding is that they're encouraged, but not mandatory.
So in F1, so you must show evidence of participation in at least one QI project for the end of year ARCP. So you don't have to do your own QI project, but you must at least be involved in an ongoing one.
Okay, and what about in F2?
So in F2, you must do your own QI project in F2.
Okay, yeah, you must complete a QI project. And I would say, as part of my lots of roles in medical education, I do interview for jobs more senior to foundation program, further on from foundation program. And one of the things that you will have to do throughout your career is build up a CV, build up a portfolio of things that you have done. Now, if you just do the bare minimum, as Lauren has said, you participated in a QI project in F1 and then completed one by the end of F2. Well, I would say that all other foundation doctors will have achieved that. So how are you going to show you're different? So I would actually think about doing more than one project. It's a good opportunity during foundation program to have a good look round and see what things could be improved, and a good time to get involved in work like that, which will help you further on down the line. And the last thing I'd say is it's an absolute expectation, it's in good medical practice, that all doctors will participate in quality improvement as they go through their career. So Lorraine and I, as dare I say it, more senior doctors to Lauren, will still be participating in quality improvement. We have to do so. And so the sooner you get used to it, how it works, there are frameworks for doing quality improvement, the better off you'll be. Thanks, Lauren. The next question was about reflection. Who gets to see our reflections if we do share it? I've heard somewhere that our reflections can be public and to not write anything that went wrong, as we can be penalised for that. Well, there's a few things in there. The first thing I'd say is who gets to see our reflection if you choose to share it is anyone who has access to your e-portfolio. So that will be your named clinical supervisor and your educational supervisor, your foundation program training director, and possibly your foundation school director, and that'd be it. So it can't be it's not just anyone will be able to read it. It will only be people who have access to your e-portfolio, and that access is controlled very tightly. Just taking a step back from there, if something has gone wrong, you should have told somebody. You should have discussed that with a senior doctor at the time, because of course, if something's gone wrong, you need to make it go right. You need to make sure that whatever error has been made or thing that's gone wrong, it may not be an error, but something's gone wrong, we need to put it right. So you need to talk to your senior doctor, whoever that may be. It may be someone who's fairly adjacent to you and an IMT or a core surgical trainee or something. It may be someone more senior to that, a registrar or a consultant. But you should have talked about that at the time, and it should all be documented. So if that's the case, then there shouldn't be any issue. In terms of reflecting on when things have gone wrong, in fact, when that has happened, it's actually what we want to see our doctors in training do. So where you have been involved in a significant incident, you will be expected to declare that every year on your Form R, the form that you have to fill in towards your ARCP. And actually what we would look at then is your reflection on it. And if you've reflected and said, yeah, I realized it went wrong, I did something about it, I sought help, I've thought about what my reaction to was what it was, how I felt about it, and what I've learnt is so it won't happen again, then that's fine. That'll be it. Done. But on the other hand, as I have seen, unfortunately, in my career, if someone reflects or writes something along the lines of "it wasn't my fault, it was everyone else's fault," then that's not so good. So actually, if you reflect well on something that went wrong, you won't in any way be penalised for it. Indeed, it would put you, put you in credit, really. So I'd really, you don't, again, I would really emphasize, because I know there is this perception that you should only reflect on when things go wrong. You can reflect on when things go well. And that is a really valuable thing, because if you learn about what went well, how you felt about it, and what you're going to do next, i.e. do it more and more and more, then that is learning. But if something has gone wrong, firstly, when it happens, you should be declaring it straight away, not trying to hide it. And if you do reflect on that appropriately, showing what you've learnt and how you're going to behave differently next time, then there will be no penalising of you. And the GMC have made that really, really clear, that they will not be seeking to, where someone has reflected appropriately after any sort of incident, then that's absolutely fine. And I've had, and people like me and Lorraine have had lots of discussions with the GMC about this, and they've made that really, really clear that they won't ask for people's reflections to read if you're under disciplinary action. Although I would say the number of foundation doctors who have disciplinary action before the GMC is vanishingly small. The chances of you having it is virtually nil. Okay, I know people really worry about that, so please don't worry about that. But what we do want you to do is, when something goes wrong, we want you to immediately raise it with a senior so that you can make it right, and then reflect on it to what you've learned and what you could do differently next time. Another question. So this is for Lorraine. I find the tab and the PSG a bit repetitive, and in a small department are often asking the same people. Could you just tell us the difference between the tab and the PSG and how they should be used, Lorraine?
Yes, all foundation doctors, both in F1 and F2 year, need a minimum of one of each, one tab and one PSG. Usually we suggest that you try to do the tab perhaps in the first placement. As Lauren, in Northern Ireland, we use the October reminder, and the PSG in the middle placement. But of course you can do more than one, that's just the minimum. The difference really between them, the TAB, as the acronym suggests, is a team assessment of behaviour. So that pertains mostly to your interactions with your wider multidisciplinary team. So you should, and within the guidance, you will all know that you are required to send tickets to a pre-described variety of healthcare professional colleagues. In other words, not just your senior clinician doctors that are supervising you. So that is so that you can get 360 multi-source feedback regarding your overall level of behaviour, attitude and team working skills within the wider team. The PSG, the placement supervision group, pertains and relates mostly to your clinical performance within that 4-month placement. As such, the members that make up a PSG will be determined usually by your named clinical supervisor for that particular placement. And the members within the PSG will usually be the senior medical clinicians in that environment, or it may include obviously a senior nurse or others, but those members will be determined by your clinical supervisor. For the TAB, as Lauren suggests, you need an awful lot more people. So we, for example, might recommend that it's probably not the easiest to do when you're maybe in a rural general practice setting. You might want to keep your tab for when you're in a bigger and busier environment in an acute hospital. The placement supervision group does only require a minimum of 3 contributors to that. So it probably is not so tricky which environment you're in, whether or not you're able to get that. But the key difference between the two, in summary, really is the tab is all about your behaviour and your team working relations, and the PSG is all about your clinical performance. Does that answer the question?
Thank you, Lorraine. That's a lovely answer, and those are really important distinctions. That you are asking about two different things, although that they are interlinked. They are different questions, and that's why we do them both. Thank you, Lauren. A question for you. For SLEs, supervised learning events, are some of these can they be also basic procedures like venipunctures, cannulations, arterial blood gases, things like that?
So for SLEs, DOPS come under the SLEs. So, you know, an arterial blood gas could be a good example of a directly observed procedure. But things like venipuncture that you're doing all the time usually is not, you know, done as a DOP. It's something that you want supervised and you want feedback on what you're doing.
The key is really that a DOPS is observed by someone, and you might not necessarily expect those to be observed. But if they were observed and it was something that was really quite hard, so remember venipuncture or cannulation, you know, can be easy, can be difficult. You could have that, but it needs to be observed by someone. Lorraine, something about who can sign them off. The question was, can F2 doctors or clinical fellows sign these off? And someone else has said, can any grade doctor sign our SLEs? Who can sign off SLEs?
I think really the caveat is someone that is obviously more senior, more experienced than yourself, and is in a position to sign off competency or observe and supervise a particular event. So in the case of ADOPS, for example, it can be for an F1 doctor, it could be F2 upwards. For an F2 doctor, it would obviously need to be the grade above that. So for all of the SLEs, it doesn't again always have to be a doctor. Again, it might be a nurse practitioner or another very experienced healthcare professional, as long as that professional person is adequately proficient, trained, and senior within themselves, within the observation that they're signing off and giving feedback on. And for the placement supervision group, and that would be the same. It would need to be senior clinicians or others that are in a position to comment on your performance and or your aspired level of performance, I think. So
Yep. So long as they're competent in that, you know, procedure or whatever it is they're doing, they're competent to take a history and examination when they're watching you, then people can do it. But it does need to be somebody who's senior. So F1s can't do an SLE for other F1s, F2s can't do an SLE for other F2s. But apart from that, we're happy to see any. And much more important, as Lorraine's talk pointed out so well, is it's the quality of the feedback. That's the important bit for learning from an SLE. So long as people give you good feedback, that's absolutely fine. Lorraine, a good question here. Can you explain the kind of DOPS that could be performed in the GP setting? So, for instance, would vaginal examination done as part of a consultation be categorized as a DOPS, or would that be something else?
And something like that, quite an intimate examination, is obviously going to involve the need for really good quality communication with the patient, and explanation of the patient before doing the procedure, and ensuring their comfort and relieving their anxiety or distress during it. So I would maybe feel that that's a little bit more complex and a little bit more layered than simply the DOPS. Whilst the procedural and practical part of it is obviously a procedure, that might be something more relevant to being, you know, a mini CEX, for example, or a CBD if it is a patient in the GP surgery that, yes, is having the procedure, but obviously there will be maybe a complex history or examination involved also. You might want to do that as a CBD with your general practice trainer. But the short answer is any procedure in itself, of course, can be a DOPS, but I think it's probably wiser to look at the context and the opportunity for it to be an even bigger learning event than just the procedure itself.
Okay, thanks, Lorraine. I'll answer this one. Is there any way of adding any educators' notes on the reflection like we do in the GP portfolio? Well, I think firstly, we have two different e-portfolios within the foundation programme, so we need to be clear about which e-portfolio we're talking about, the Churras one or the Horus one. Unfortunately, there probably isn't anywhere as things stand. I do think that it is a good thing to be able to add some notes. Something I've done with trainees in the past is say just do it on a I don't know, Word document or a note on the computer, which as the supervisor I would then annotate with further questions or points that I'd like to make, usually encouraging and often just more questions about to prompt the doctor in training to think more widely. And then we put it in their e-portfolio just as a document, and under reflections just said please refer to this document, and that's an alternative way so that you can actually have a dialogue, because that's reflection can be a dialogue between you and someone senior, so that they're always prompting you to do more. It may be something we can look at with the e-portfolio. And then so yeah, good point. A question for Lauren. Sorry if this has been covered, but what is the difference between a mini CX and a DOPS? Couldn't a cannula also be written up as a mini CEX?
Hi, yeah, so that's a very good question. So for me, for a mini KEX, usually it's something, as Lorraine said, a bit more complex. So something, that involves maybe a history, an examination, and then maybe also carrying out the procedure in order to fill out a mini KEX. And something like a cannula, as long as it's being supervised, can of course be a DOPS. But I would usually refer to mini KEXs as something a bit bigger and requiring a bit more work, and maybe more than one thing required, as well as your procedure.
Yeah, Lorraine, anything to comment on that as a foundation school director?
Yeah, no, just exactly what Lauren has said. I think that the DOPS in themselves it's just purely procedural, and we understand that as doctors, of course, we all, as we're doing any procedure, even taking blood, we obviously communicate with the patient as we're doing it. We don't just go up and stick a needle into somebody without any form of non-technical skills of communication, but often that will not be directly observed. So I would just reiterate everything. I think Lauren explained it very nicely.
Thank you very much, both of you. There's another question here about QI, and having gone to the curriculum, says about showing involvement rather than a full project. I think one would certainly expect much more involvement in F2 than F1. I think there's something to be said for doing a project in F1 and then you don't have to do another one in F2 if you don't want to, although I'd go back to the more you do, the better off it is. Final question, the time we've got for us. Lorraine, what other procedures could be done in the GP setting? What sort of things, if we're looking for procedures, could be done there?
Oh gosh. Well, firstly, disclaimer: I'm not a practicing GP, but I would imagine a vast variety of just pure procedures, including some that the example Mike used even about, the colposcopy or other things that aren't done maybe in a hospital setting, or in areas that foundation doctors might work in. So I think many practical procedures, and also the opportunity for many KEXs and CBDs as well as DOPS. But in terms of procedures, what you could do if you're replacing a GP surgery very often, and again, I'm speaking about how it works within Northern Ireland on the assumption it is not dissimilar in the rest of the UK, but most general practices will of course have treatment rooms. They will have other members of the team in the health centre wherever the practice is. So there's obviously going to be patients going for ECGs, to have bloods taken, to maybe get an ABG, and actually to have other procedures carried out, not necessarily by the GP. The GP themselves will obviously do things like cervical smears, examinations of the patients, taking blood pressures, etc., etc. So I think rather than even the beauty, I suppose, of a GP placement is you wouldn't just be limited to the direct procedures the GP themselves would be doing with the patient, but also the patient's journey throughout the primary care setting, whether to the nurses or the treatment room or the pharmacist, for example.
Great. Okay. Well, we've come up to our time now. So thank you very much to those of you who sent in questions and those who've been listening. I hope it's been enjoyable and useful. Thanks very much indeed to the UKFPO team for their behind the scenes work, for getting all this done. And I'd like to particularly thank Lorraine for your insights into good feedback in your answers to those questions. And Lauren, thank you so much for giving up your time and an excellent presentation about how to use the ePortfolio well, and again for answering those questions. So thanks very much to everyone. Have a good afternoon, and we look forward to seeing you in our next webinar next month.